The cervical spine is the most mobile segment of the spine, predisposing it to a higher incidence of injury. The CI5 to 7 vertebrae are susceptible to injury from diving accidents, car crashes, and falls, leading to various types of fractures and dislocations. Cervical spine injuries are a critical concern in trauma patients. They are relatively common due to the high mobility and exposure of the cervical region. In the context of major trauma, cervical spine injuries occur even with seemingly minor head or neck movements. There is an association between cervical spine injuries and head injuries. Cervical spine injuries should be considered in all patients with severe TBI unless ruled otherwise. Cervical spine injuries can range from minor whiplash to life-threatening conditions including spinal cord injury with permanent disability. Spine X-rays are the first investigative modalities for spine injuries. The primary imaging is anteroposterior (AP) and lateral views. Spinal X-rays reveal fractures, dislocations, and alignment issues but may miss subtle injuries. Computed tomography (CT). If X-rays are inconclusive, a CT scan is the next step. It provides excellent visualization of bone details, alignment, and fracture characteristics. Magnetic resonance imaging (MRI) is especially valuable for detecting injuries that may not affect bone, such as spinal cord contusions, disc herniations, and ligamentous injuries. Cervical spine injuries in trauma patients should be highly suspected in cases moribund, where patients show any neurological deficits or changes, report pain in the neck area, or have a limited range of motion. These symptoms have severe implications and require immediate assessment. We should always assume a cervical spine injury in trauma patients until proven otherwise and use immobilization as a precautionary measure. A cervical collar should be applied in cases of major trauma to minimize movement and prevent further injury. A clear X-ray can rule out cervical spine injuries. Clearing the C-spine is based on clinical criteria and imaging. Injuries such as lacerations to the head, forehead, or jaw should heighten clinical vigilance for cervical spine injuries. Canadian C-spine rule is a clinical decision-making tool to determine when to use radiography in trauma patients with a potential cervical spine injury. Imaging is only necessary if high-risk factors such as age, over 65, dangerous injury mechanisms, and paresthesia in extremities are present, if low-risk factors that allow safe assessment of range of motion are absent, or if the patient cannot actively rotate their neck to 45 degrees to the left and right, then radiography is indicated. In summary, there is no indication of a C-spine X-ray if the patient is awake and alert with no neck symptoms on voluntary movements. All other trauma patients where a neck injury is a possibility should be X-rayed. For radiographic evaluation of the cervical spine, 3 specific views are typically required. Lateral cervical X-rays. This view should display from the base of the skull down to the first thoracic vertebra. To ensure an unobstructed view, the patient's shoulders may need to be pulled down, often achieved by traction from the foot of the bed. FAH anteroposterior view. A true AP view provides a front-to-back perspective of the cervical spine. Odontoid view. Open mouth view, aimed at visualizing the odontoid process of the second cervical vertebra. Possible X-ray abnormalities seen in cervical spine injuries include odontoid fracture, a break in the odontoid process also known as the dens, a projection of the second cervical vertebra, wedge fracture of the anterior vertebral body, a compression fracture where the front of the vertebral body collapses creating a wedge shape. Burst fracture occurs when the vertebral body is severely compressed, causing it to fracture and send pieces outward. Fracture of spinous process, a break in one of the bony projections off the back of a vertebra. Fracture of transverse process, a break in one of the 2 bony projections on either side of the vertebral body where some muscles of spinal movement attach. A normal lateral C-spine X-ray should show the vertebral bodies lining up in a straight column without any displacement. The intervertebral disc spaces should also be uniform in height. The spinous processes should form a regular straight line down the back of the spine. The posterior vertebral line and anterior vertebral line should be continuous and smooth. The prevertebral soft tissues should not be swollen or thickened. The cone atlas should articulate properly with the odontoid process of C2 axis, and the joint spaces should be clear and distinct. The curvature of the cervical spine should show a gentle lordotic curve. In assessing cervical spine, C-spine, injuries on a lateral view X-ray key points to observe include alignment. Check for any abnormalities in the alignment of the anterior vertebral line, posterior vertebral line or spinolaminar line, fracture of the spinous processes, widening of the spaces between the spinous processes, anterior soft tissue widening, swelling or increased space between the air in the pharynx trachea and the anterior aspect of the vertebral bodies. In the context of trauma, the lateral C-spine view is part of the initial assessment to rule out cervical spine injuries before moving a patient. However, it's important to note that a single lateral view cannot reliably exclude all cervical spine injuries. If there's suspicion of injury or the lateral view is inconclusive, additional imaging studies, including anteroposterior, AP, and odontoid, open mouth, views are often necessary. Anteroposterior, AP, views of the cervical spine, C-spine, complement lateral views by providing a different perspective that is crucial for a comprehensive evaluation of the cervical spine, especially in the context of trauma. AP views can demonstrate vertebral body fractures, spinous process fractures, facet joint dislocations, or transverse process fractures. The findings of a normal odontoid view X-ray, also known as the open mouth view, include an odontoid process centered within the ring of cone, atlas, symmetrical spacing between the lateral masses of cone and the odontoid process, clear smooth margins of the odontoid process without any breaks. The findings of an abnormal odontoid view might show displacement or asymmetry of the odontoid process relative to cone, suggesting a fracture or dislocation, a break or irregularity in the outline of the odontoid process, increased or uneven space between the odontoid and the lateral masses of conial. This open mouth view shows an odontoid fracture. Fractures of the odontoid process of C2 odontoid fractures are common in older adults due to falls. Cervical fractures result from direct trauma to the head or neck and can be caused by several mechanisms. The subsequent slides demonstrate these mechanisms. Compression. Vertical force drives the head downward, causing the vertebrae to compress. This can lead to burst fractures. Loading forces can lead to multi-level fractures. Hyperflexion. The head is violently jerked forward, increasing the spine's normal forward curve, potentially fracturing the vertebral bodies or dislocating vertebrae. This can present as compression of vertebral body and disruption of posterior ligaments. Hyperextension. The head is forced backward, straining the spine backward, and possibly leading to fractures or dislocations, particularly in the posterior elements of the vertebrae. Rotation. Twisting injuries can lead to fractures or dislocations due to the rotational force, especially when coupled with flexion or extension movements. Lateral bending. Side-to-side motion can cause a symmetric loading of the spine, leading to fractures on the side opposite the direction in the bend. These mechanisms can act in isolation or in combination during traumatic event. Distraction is another mechanism of cervical spine injury, where a longitudinal force pulls the spine apart. This type of force can occur in situations such as when the head and neck are suddenly pulled upwards, or when the body is violently pulled downwards. This can lead to stretching or tearing of ligaments, dislocations, or even fractures as the normal stabilizing structures of the cervical spine are disrupted. Distraction injuries can be particularly dangerous as they can cause severe damage to the spinal cord. When moving a patient with a suspected neck injury, extreme caution is vital to avoid exacerbating the injury. The key steps include: support the head with 2 hands, one at the base of the skull and the other on the chin to maintain neutral alignment. Apply gentle traction to prevent movement that could cause further injury. Use the lug roll technique to move the patient, ensuring the head and body turn simultaneously as a single unit. Have at least 3 people to support the patient's body, with 1 dedicated to supporting the head. These measures help protect the spinal cord during the critical initial management. The management of a cervical spine fracture typically includes applying a rigid neck collar or placing sandbags under the neck for immobilization, performing a primary trauma survey with airway, breathing and circulation, ABCS, stabilization, conducting a thorough neurological examination to assess for any deficits, carefully log rolling the patient with adequate head and neck support to inspect the back, palpating the neck to check for tender areas or unusual softness between the paraspinal muscles. Consider C-spine instability when neurological signs or symptoms indicate potential spinal cord or nerve injury, X-ray signs of misalignment or damage to the spine. Significant neck pain or stiffness suggest underlying damage. A soft body space is palpable between the spinous processes, which could indicate a hematoma or disruption of ligaments. The patient is unconscious, making it impossible to assess pain, neurological status, or range of motion reliably. Immobilization. Application of a cervical collar or skeletal traction. A halo brace is used in the management of cervical spine injuries, especially for cone C2 fractures when rigid immobilization is required, but surgical stabilization is not indicated. A thorough medical and neurological examination is essential. Radiographs, CT scans, and MRIs. Pain management and, in some cases, administration of steroids to reduce inflammation. The surgical decision is based on the type of fracture stability and any neurological deficits. Surgery may be required to stabilize the spine and prevent further damage. Early rehabilitation for mobility and strength is important after stabilization. Skeletal traction of the cervical spine is used to reduce a cervical fracture dislocations and immobilize the C-spine. The widely used traction device is the Gardner-Wells tongs. You will practice placing these tongs on a simulator. The overall goal of traction in the case of cervical fractures is to stabilize the fracture, decrease pain, and minimize the risk of spinal cord or nerve injury while awaiting definitive treatment, which may include surgery or immobilization in a brace or halo vest. Caring for a patient in skeletal traction, particularly for a cervical spine injury, involves meticulous attention to both the mechanical setup and patient well-being. Traction must be aligned with the body's axis. The bed's head is elevated to use gravity as counter-traction. Weight ranges from 3 to 8 kilograms, tailored to the patient's size and specific injury level with periodic X-ray checks to monitor progress. Nursing care is critical to prevent pressure ulcers and other complications. An ideal setup includes a bed with a pulley system for optimal traction application. Regular assessments and adjustments are crucial to ensure the traction is effective and that the patient remains comfortable and complication-free before discontinuing traction. Assess the fracture's stability and the adequacy of alternative immobilization methods.